Hi, this is Mahesh.
Hi, I'm Smriti, and this is Leena Gangolli, Dr. Leena Gangolli. Welcome to another episode of Living Well, the Living Well podcast. Thank you for coming onto this podcast, Leena. We're very grateful that you could find the time to come. Uh, could you start with telling us a little bit about yourself?
Okay, so where do I start? Okay, so I was born and brought up in Canada, but I've lived most of my life in India. Um, from a young age, I was so we used to come to India for our holidays. So I grew up with at my grandmother's place, and what I found very exciting whenever we came to India was the presence of so many elderly people in the house, because my grandmother would necessarily have her cousins and everyone come over to see her grandchildren, and they would all stay over at our place. And I remember all the beds were always given to the elders, of course. So we would come in from Canada with our sleeping bags, and our mom would tell us that you'll be camping in Bombay. And I still remember every night. So at that time, obviously, you didn't have the imported products that you now have in India. So we would fly in with Polydent tablets for everyone's dentures, and at night, my mother would set about 3 or 4 glass bowls on the countertop and put everyone's set of dentures into the bowls. And my job was to put the Polydent tablet in each one, so the dentures. And I still remember standing there at night and just watching the dentures being cleaned. And then in the morning, remembering which set went back to which elderly person. So I grew up with a lot of elderly people around me. I received a lot of love from them. And I think that's where from a very young age, my desire to, at some point work with the elderly came up. Wanting to become a doctor was because I grew up in a house where my father's a doctor, my father's a psychiatrist, and he's a geriatric psychiatrist. So he has, there were always books around the house about geriatric psychiatry, Alzheimer's, dementia, the entire lot of things. And apparently he still has 1 or 2 textbooks that have my scribbles in the margins, because I couldn't read yet. But I used to pick up a pencil and scribble in his textbooks, and they were library books, so he had to finally buy them from the library because they were defaced.
no.
But they stayed with us for that reason. But yeah, so then we moved to India. As my grandmother was aging, my mom felt that she would like to be with her mother, and obviously my grandmother. And my grandmother also thought that it would be nice if my sister and I just experienced life in India. And she said that, just try it as an experiment. Try it for 2 years, and if you don't like it, you can always go back to Canada. But if you like it, you might just take root here.
Lovely.
And well, that's what we did. We moved back when I was still in the tail end of elementary school. So came back in the 9th, and it was supposed to be a 2-year experiment, but I'm still here.
So how would you describe it? Did the experiment succeed, or would you?
So the experiment is still going on.
It's still going on.
Yeah.
It's a long trial. But I like how you mentioned the fact that you had a background of family members who are seniors who require care. You come from a space where your father is already dealing with this specialty, a subspecialty of this. So when you entered geriatrics, if someone's listening to us right now, how would you describe what is geriatric medicine? So someone might say, what is that word, because someone might not know what it means.
Yeah. So, by definition, it is the care of the elderly. So it's people above the age of 65. Okay. Some countries define older adults as 60 plus, some as 65. Okay. And
sorry to interrupt, but what does India define it
India
as?
is a 65.
So anyone above the age of 65
Yes.
is elderly.
Yes.
All right.
Okay. So you have the elderly, and then now they have the super elderly.
Okay.
Who are the people who
They
are
have
80
superpowers.
They should have superpowers, but they're 80 plus.
All
So,
right.
for example, you may have noticed all the bank billboards always have a different interest rate for the super seniors, right?
Okay.
It's about
Okay.
0.5% more than the standard rates for the banks.
Okay.
So, some kind of financial I wouldn't call it assistance, because this is
Incentive. It's a probably
maybe,
incentive
yeah.
to plan their finances
Yeah,
better.
to help plan their finances and give them a little extra interest, or
That's right.
you know. So yeah, so the super seniors are people who are above 80.
80. All right.
And what's important to understand is that age doesn't necessarily, like someone at 65 to 70 to 75 can still be very healthy and very active. Yeah. So although age isn't, it's not really just a number, it's so many other things. So a person can actually still be very healthy and very active. And actually, we do encourage people to have second careers. So if they are in the government sector, and if, for example, they have retired because that's what the law says they need to do,
Correct.
you know, it's really important that they take up something after that, and they stay socially engaged, and they stay, you know.
Because I think the science mandates that the more engaged you stay,
Yes.
the better it is for your brain,
Yes.
for your overall cognition, for
Yeah.
your overall sense of well-being,
Yes,
isn't it?
that's absolutely true. And
So-
social isolation is now the new risk factor, right? So
Right.
social isolation, which sometimes happens almost automatically with retirement, because
Yes,
that
correct.
whole structure that we're used to of going to work and getting up with a purpose, the structure of the day,
Everything
possibly,
is around
yeah,
your
even the
workplace.
financial power that you wielded in the family, right? Then you
Right.
you were a breadwinner, so you were a decision maker as well, and these dynamics change, and they change especially, for example, in joint families, where a person who was the head of the household now no longer is the head of the household, and that could change dynamics as well. Yeah, so
Got it. Got it. And so you did your geriatric training in India?
So I actually have approached. So I've actually done my training in after medicine has been in public health,
Oh, lovely.
because I've actually looked at aging from the public health lens. So not just the medical aspects, but all the other aspects of aging. So for example, things like food security, housing, you know, affordability. What things are in place to help the elderly age in a graceful and empowered way.
So this is more
possible.
about a more community-based
Yeah,
approach, I
yes.
think.
It's a bigger dimension.
It's a
then.
yeah, it is.
It's than medicine, yeah,
And,
than pure medicine, yeah.
But I think that that's a great way to look at it, because any healthcare unit that you are looking at in terms of a population unit, the one-on-one approach and the community sort of a bird's eye view of the community and what helps and what doesn't. Food
Yeah.
is such an important thing. Social isolation, food,
Yeah.
all these are such big important
Yeah,
factors.
they are. Yeah.
Where do they get their supports from? All these things, they're very important.
Yeah.
Yeah, and while we'll be recording this on Gandhi Jayanti, where he spoke about the most marginalized and vulnerable, you know.
Yes.
So the elderly, when you look at them in that context of, and that them is probably us in some time, but you
Yeah.
look at them, I think it makes a lot more sense to look at all of it from this vantage point. you know.
Yeah.
So it's a beautiful.
Like for example, even if you just look at the city that we live in.
Yeah.
You know, so many times just out of my own curiosity, I walk in areas to see what the interlocking tiles are like. I mean, those are such a high risk for falls.
Right.
You know, for the elderly, how safe is our city, right? Because,
yeah.
you know, the escalators in some of the skywalks, the escalators aren't working,
Yes.
right? So how are the elderly supposed to ascend those steps, right? How are the walkways, how have they been made? How safe are our crossings? You know, for
Yeah.
a city,
Pavements
yeah,
also.
pavements, our public transport, like, you know, and I think it's not that we can't do it. I think there needs to be political will to do it.
Correct.
In Western countries, accessibility is a serious issue.
Correct.
You have public transport like buses, where you can actually lower the front of the bus so that the elderly person can get on without having to climb the stairs. Yeah, and it's just a question of it's obviously India has the means for that kind of technology.
Of course.
We do.
Of course.
But it's just that somebody needs to, we actually need to make the elderly an extremely important stakeholder group, right? So that all these things are made accessible to them. Of course, I think, you know, I know that for things like railway bookings and things, there are discounts for the elderly,
Yes,
and there's
yes.
priority to the elderly. A lot of our government services have priority for the elderly, which is a nice thing.
Yeah.
The post
Banks
offices
have it.
Yeah, post offices have a separate line for the elderly, and I've seen that working very well
Very
in
well.
India.
Yeah.
I sometimes just do this out of my own curiosity, just take a walk to,
Yeah.
uh,
So that's like a risk assessment, because we
Yeah.
have people
Yeah.
who come to our clinics and they say that we ask them and we tell them that you need to walk to keep yourselves fit. And then they say, where do we walk?
yes,
Because they're just afraid. And I find that they're just afraid to walk in crowds because they're a little unsteady
yes,
and they just freeze when someone walks a little faster to them. So I remember in one of the Nana Nani parks, which is an elderly park, some people were walking and there was someone who was running. So they went and called the watchman and told them, tell this person not to run,
yes,
because it's so scary for them to have someone whiz past by them, because
Yeah.
they're afraid they'll fall
They'll
down or they'll
Fall
bump.
down
Yeah.
because of
So they
it.
just freeze when this person
True.
comes near, and
Yeah.
that's and
that
it's
sensory input.
that's
makes
taken
them
for
freeze.
granted.
Yeah. So yeah.
So it's interesting that this is what got you into geriatrics, but I'm also very intrigued to know how was the transition, or was it a transition from geriatrics to palliative care, and what made you get there?
So I feel that there wasn't. I wouldn't call it a transition. Maybe it was more of an evolution.
Yeah.
Because actually, what happens is geriatric care and palliative care. Honestly, the principles are very, very similar.
Correct.
Right. So you're going to look at quality of life. You're going to look at comfort, support, symptomatic management. And you're not going to look, you're not going to go after aggressive therapies. You're going to really weigh the benefit of something against, the risk of side effects.
Yeah.
And so I really feel that they almost complemented each other. It was almost just like a natural transition from, like it was almost like one was already practicing palliative care without realizing it. And then one day you learned the new label that it's palliative care. And it's really like that. It was palliative all along.
Yeah.
Because I really feel, maybe as unscientific as this sounds, but there's a lot of heart in palliative care. There's, of course, head as well. But I feel that there's really a lot of feeling, there's a lot of empathy, there's a lot of just understanding a total picture about the person, which kind of takes you a little away from the purely medical model to, just understanding this person holistically.
I think some of the principles are quite similar, right? You need a lot of patience. You need to have your listening skills honed up. You need to think about things like support systems. You need to think about what's important at this point of life, at the age of 65 or 75 or 85, and de-prescribing, or making sure that they don't have too much of a pill burden, too many medicines to take.
It's not
All
too
these
aggressive.
things,
Yeah.
exactly, it goes hand in hand with the aggression. So it's almost like a slowing down and kind of acknowledging that, okay, there is limited time left now, and let's just think about what needs to be done with this limited time, what's most important to you with this limited time.
And how can we make each moment happy, right? Like let's look at it as, it could be limited time, but let's look at it as the best times of our life. Like, why can we not make it the best times of our life, right? Like, if it means, like, for example, I had a 93-year-old lady with dementia, and she really wanted to have pani puri. Okay. And her daughter was very concerned that, she might aspirate because it's
she might
such
choke
a
on it. Yeah.
she might choke on it, because, so she said to me, but how do we do this? So I said, let's try. I said, wouldn't you be bored with moong dal khichdi every day? Said, come on, let's do pav bhaji, let's do pani puri. So she said, okay, you have to be here for that. I said, okay, I'll come, and let's make sure she's safe. And all we did was we just crushed the puris and mixed them into the mashed potato with a bit of mustard oil and jeera pani, whatever the whole thing is. We fed it to her with a spoon. And spoon feeding is absolutely safe in somebody with dysphagia, right?
Yeah.
And we did the same. We did everything, the chin tuck, the spoon feeding, but we gave her pani puri. And we gave it to her in a way that she could have it.
What was the dose?
It was 5 pani puris BID. But so, and sometimes that is just so changing for some people. Like, some families also feel empowered when I say to them that, you know what, let's look for ways to make every meal joyful.
How
right?
did she react to that when she had the pani puri?
Oh, she was so happy. She was very happy. The sad thing was she didn't really recognize me or her daughter.
Uh-huh.
But we were already used to that space. We
Yes,
knew that
because-
she wouldn't really recognize us. But she was very
remembered the
happy.
taste.
She remembered the
She
taste.
the taste, yeah.
I had another patient who used to love mava cakes from a particular Irani bakery in my area. So I live in Grant Road, and so we have a lot of these old Irani bakeries. And so whenever I went to visit him, just for his blood pressure and checkup and everything, I used to carry 2 or 3 cakes with me, just like a little, I knew he liked them, so I'd pick them up. And so one day when I was going, I was in a rush. So I couldn't go to the usual Irani bakery.
Yeah.
So I went to another bakery, just picked up my 3 mava cakes and went to his house. And as our usual practice, I used to open the packet and give him a cake, his wife a cake, and I would sit with one. We would all have our cake, and then I would, start speaking
talking,
to him
yeah,
and
yeah.
taking his blood pressure and stuff. So I gave him the cake. He opened it, he took one bite, and he looked at me and said, "They cheated you today." So it was amazing. Here was someone again who, had forgotten who his children were. He'd forgotten who his wife was. He knew I was someone who would come in once a month and check up on him, but he knew the taste of that particular
That
mama
particular
cake.
cake.
Amazing.
So it's like these little moments, which are, as I said, they're not really medical or scientific, but they're
Right.
there.
But again, I think we need to ask ourselves this
yeah.
question, that we have defined these as not being medical, but are they really not medical? They
Yeah.
that's what medicine is. I guess a
I
spirit
remember
is about,
in all the old Bollywood movies when Dr. Chacha used to come
with a bag
with a bag
and
He
feel
used
the
to
pulse and
always
tell people they are pregnant.
so that bit was maybe not so scientific, but he used to always have tea with the family, or there would always be like this, a whole thing of, okay, he has seen the patient and now he is coming in, and the bahu and the beta are sitting, and
Yeah.
and there is some chaklis,
Yeah, there's this.
and there is tea, and like there is a whole camaraderie
Yeah.
around the family doctor,
Mhm.
or just this whole knowledge that, this is a person who is an important part of the household. He keeps coming and going, and you treat him as part of the
Yeah.
of the family, and that adds, I think, to it. So things like trust with medical decisions. So many of my patients have this one family doctor that they will ask everything to.
Yeah.
Which hospital to get admitted in, who to get admitted under, who to get the surgery done from, whether to get the surgery done or not. So this gentleman may not know whether to get the surgery done or not, but they will still listen to whatever it is that
Yes.
he or her will tell them.
Yeah.
So
So it's like,
I like how you use the right word. It's trust. I like how they welcome you to their houses. How that trust is established, and even if they are a shadow of what they used to be in terms of their memory, there's still this bonding that takes place
yes.
in geriatrics. That's very interesting to see
Yeah.
that.
But I want to ask you one question that even I get asked a lot as somebody who works in palliative care. But I will ask you this from the kind of the point of view of looking at of seeing a lot of elderly patients. Isn't it depressing?
Okay, so it's like this. Can you go out into the rain and not get wet? Right? You do get wet. So when you're seeing a lot of people, there are times when you will feel sad. Okay. Now, is it depressing? I don't know. Sadness, yes, sometimes. Sometimes a sense of helplessness, yes. Because you don't always have happy stories, right? Like you don't always have the daughter who's willing to make pani puri, somebody else who's willing to get the mava cakes. You also have neglected people. You have abandoned people, and you work with a complete spectrum of
Correct.
different realities. And yes, some realities can be difficult to work with. Is it difficult to work with? Yes. Can you still try to find a moment of joy in that? Sometimes if you are, if you're lucky, you might still find a moment of joy. Like even in someone's complete hardship, if you can just find that one little moment where the two of you laugh about something, right? Before you leave. Like I kind of think to myself sometimes, at least before I leave the house, I want to see this person smile. And sort of at least that little moment of joy. And the measure of time, anyways, is moment to moment, right? I mean, you're not going to be able to measure too much time in the space that we work in. So,
So if there's someone out there who's interested in medicine, who's interested in pursuing medicine. So you have a trifecta of areas where people don't want to go in. Community medicine, geriatric medicine, and palliative medicine. So you have like concentrated these three and you're doing what you're doing. What would you tell them whether they should be entering this field of geriatric palliative care?
so I would certainly say give it a try. See, the thing is, maybe it's also because at the stage where they're making the decisions about their post graduation, they're still in their early 20s most of the time.
Yeah.
So maybe they've not really cared for a parent or a grandparent or a relative yet.
Yeah.
The role of a caregiver is going to come to all of us at some point, right? Either in our personal lives or then we make a career out of it. But it's going to face us. And maybe at that age, because they've just been through a very, I mean, it's just the way the curriculum is built and the exposure, because we've all been medical students too, right? So we know when we did our ward work and stuff, we know what we were exposed a lot to, what were seen as the, you know, the subjects that you could just read just before the exam and go and give your paper, and community medicine was one of them. I mean, come on. All of, like, who really
We
held
had
the
that.
blue?
Did we have that as a sub? Oh, we had
Yeah,
that.
it was PSM. It was called PSM. It was called PSM. It was a blue textbook. And I
Really?
think everyone read it the night before the exam. So I plead guilty to that as well, that I never thought I'd go into community medicine. Because I think it's something that you actually evolve into. So I wouldn't necessarily, I mean, I feel that even if young students take up something else, like they might take up, I don't know, respiratory medicine or something else, at some point they will be able to
Yes.
incorporate palliative principles
Yes.
into their practice. And in fact, I don't think there's a single discipline
Yes.
that will not have space for palliative principles to be
Correct.
integrated into it. So ultimately, at some point, they may not necessarily do an MD in palliative medicine, but maybe as they evolve professionally as well, and they're in their 30s and 40s, they may actually find themselves incorporating those principles because they will start caring for family members as well.
That's right.
And I think personal experience is one of the strongest drivers,
Oh,
you know,
yes.
compared to
Yes.
what you're immersed in the wards as medical students, and you care for one grandparent or one loved one,
Yes.
it just changes the whole thing.
I mean, I
So,
think everybody that we have had on the podcast has had some story from their childhood or from their young adult days that has kind of got them into
Yeah.
this path.
yeah.
You're the first one at dentures, though.
Yeah.
There is now the what I also want to ask you about is where you are working at presently, which is it's not a it's an uncommon place of work in the sense that it's one of the few standalone palliative care centers in the city and even in India.
Yes, you're right.
Can you
In terms of non-chronic, yeah, you're right.
and especially because it focuses on non-cancer
Yes.
Non-cancer, yes.
non-cancer palliative care, which is
Yeah.
again a more niche branch of an already niche branch. What's it like working at a pure palliative care center? How has that added to your?
So that's actually been really exciting. I mean, if I can call it exciting, but what I mean is it was something I always wanted to do. Because I did realize that although palliative care is really important, the focus was on, I mean, just historically, the way palliative care came around was it was associated with cancer and the
Cancer.
needs of
Yes.
cancer. Now, I'm in no way saying that I mean, of course, patients with cancer need palliative care, but they comprise about 7% of the population that needs palliative care.
Correct.
There's about 93% of the population with non-cancer conditions with an equally distressing symptom burden.
Yeah.
So, for example, neurological, neurodegenerative cases,
Diseases.
people with end organ failure, right? Like people who have, for example, a cirrhosis, which is not going to be curable and they're not fit for a transplant. And so they're going to be in end-stage hepatic failure, liver failure. Their symptom burden is going to be very high,
Yeah.
right?
Yeah.
Comparable to someone or maybe more than
With
someone,
cancer.
yeah?
Yeah.
And I never think it's fair, even ethically, to quantify suffering because suffering has so many dimensions. So I never want to say that this has more suffering than this, and
Yeah.
therefore this deserves an inpatient unit. And so what we have consciously made a decision at Sukoon Nilaya is we want to meet the unmet need of people with chronic conditions not limited to cancer.
Yes.
Okay, but for us, cancer is not an exclusion criteria.
Yeah,
So we
yeah.
do accept cancer patients as well.
Hmm.
We have never turned away a patient with cancer, but the thing is, our focus is on non-cancer because that is an unmet need in the
In the
There
city
are
at the
some-
moment
yeah,
and society.
everywhere
Yeah, you're
actually.
right.
Yeah. So it was
there are
very
very
exciting.
few options
Yeah.
for patients with non-cancer
Yeah.
illnesses
So
if they need
yeah,
to.
and inpatient care is really important because although home care is also important,
Yeah.
what happens with some of the cases that we have is they need very acute medical care as
Mhm.
well, right?
Yes.
So they need their IV lines, they need IV fluids, they
Yes.
sometimes need IV antibiotics because our structures, we give medical interventions as well, right?
Yes.
So we'll do the Riles tubes, we'll do what may not necessarily, we do acidic tapping. So what may not necessarily be safe in a home
Home
setting.
setting.
Yeah.
And they
yeah.
need
So
space.
they need the space, the
Mm.
safety, and someone recovering from a
A
stroke, for example.
hospital-like
Yeah.
environment
Yeah.
where things
So they
are...
need it. So this is something I always wanted to do. So when this came up, this was like like the ant that wanted to go to Mount Everest, right? So the ant wanted to go to Mount Everest. Obviously impossible. So what it did was it climbed onto the knapsack of one of the mountaineering groups, and it just reached Mount Everest, because they did the climb and this ant went along. So I really feel like that. It's something I always wanted to do. King George V Memorial and Cipla Foundation came up with this project. They gave the infrastructure, the funds, and everything. They needed a palliative care physician to step in and be there.
Yeah.
And I was the ant. I kind of went up.
You're being very modest there, but because the kind of work that you do with people who need these specific conditions, not limited to cancer, and then the geriatric space, that adds a lot of value to what you're doing. One question about, you mentioned one of the, not all stories are great. There are stories of abandonment. So I believe that there is a law that protects senior citizens. Can you tell us a little more about
So
that?
there is the Ministry of Social Justice has come out with I'm not sure the specific name, we can Google it, but it's the Protection of the Welfare of Senior Citizens, or it's basically kind of the short form of the Senior Citizens Welfare Act, and
Okay.
it basically protects senior citizens. Specifically, it makes it the duty of the children to take care or to
of their
provide
parents, yeah.
maintenance for their elderly parents. And it gives the parents the right, especially if they have transferred their property to the name of their children. Many of them, in their lifetime, they transfer
They
property
do it. Yeah.
so that there won't be problems later on. So they transfer property by way of a gift deed or whatever.
Yeah.
And then, unfortunately, once the transfer has happened, some of them then can get neglected. They can get, put out of the house. So the act was made to protect them and make maintenance from the children an enforceable right. Now,
Right.
this is the truth about any law, okay? It's as good as it is enacted.
Yes. Yes.
And to enact it, somebody actually has to move the court to get that right enacted. Given the mindset of, I don't know, I can't fairly say that this is an Asian thing. I don't know if in the West a parent would sue their child. I can't say that. But just generally from the pulse that I have felt in society here, I don't know if any parent will sue their child.
Yeah.
They just won't. I mean, that's just the way things are. So although
the act is there.
The act is there, but somebody needs to.
We don't know how well enforced it is.
As I said, an act is as good as it's enacted, right?
So you mentioned something about the West. So how does the West compare in terms of the care of its elderly and palliative? And how does India compare right now in your space that you're working, if you compare both?
So to be fair, the West doesn't necessarily have happy stories either. Okay. I mean, unfortunately, I think the world over, elderly people are vulnerable. And the more dependent they become, either on their children or on a system, right? Like as soon as they lose their independence and they now become dependent on somebody else to care for them, I think the level of vulnerability is really the same across the board.
Right.
You're right.
There were a lot of instances in, developed countries. I was reading some of the literature from Canada, Australia, the UK, where homes, senior citizens, the food being served is not necessarily nutritious food. I mean, they get a certain amount of fund, like for example in Canada, they get a certain amount of funding dollars per person or per beneficiary.
Yeah.
And it's up to the management to, ensure that that money is used for these people. And there are actually reports showing that that's not how the money's being
So
used.
the mismanagement ends
There's
up
mismanagement,
happening.
yeah. And these are people who unfortunately don't have a voice.
Yeah.
Right? So
Yeah.
they're not going to speak up and say that, last night I was just given one sausage and some potato chips. Because this was literally like the photographs that some relatives had taken and posted, was that people were actually being given, tinned sausage or tinned food. And well below the budget that was allocated for these places. And this is, different countries have this. So unfortunately, I think the elderly are vulnerable, and
Across
I think
board.
across the board. And I think maybe, I would hope again, and it's about political will, that there would be some kind of body that oversees these things and maybe has some way of holding accountable,
Yeah.
homes like this that are being run and are not necessarily using the funds that are being dispersed.
Yeah.
I mean, there were a lot of tragic stories even during COVID. Long-term care facilities. I can speak for Canada but they, the neglect that happened, and
Yeah.
It just ran through the disease, just ran through elderly homes. Yeah.
And I'm sure that even at Sukoon, Nilaya, you must have come across instances of abandonment.
Oh yes, that's almost the norm for us then. And it's really difficult. I mean, that's emotionally difficult for the whole team, actually.
Yeah.
Sometimes when we have our little team huddles, we all ask this question that, you can give medicine for pain, you can give something for breathlessness. What do you do for someone who has no one who loves them, right? And then we think, okay, so then we will be the ones who love them, right? And we try to be there for them. But it's really,
How does the team cope with that?
Yeah, she said there's an emotional huddle that.
Yeah.
So is it like a brainstorming session before you go for your rounds? How do you function?
Yeah, so before our rounds, so I'm generally in the center by 8:15 in the morning, and my team is my team's all there by 8:15, 8:30. So we do what we call a board round first. So in our room, we have a whiteboard that has all the patients' names and the bed number. And so that we're not going to have any discussions at the patient's bedside about prognosis or about what the family has told us or whatever. So we have that in my room first. And we just go as per the names on the board.
Yeah.
So we have a board round. We talk about anything that needs to be talked about, and then we go out into the ward. And it's still the multidisciplinary team. So it's usually myself, one of the doctors with me. We have 2 medical officers now who are junior to me. So one of them would be with me, a nurse, our social worker, our psychologist, and we have a peer counselor. So that's
Lovely.
the minimum with us. And we go to each bedside, and that time is used only to talk to the patient and the family member or the caregiver if they have any concerns, and just to acknowledge them, because so many times, for example, we have a couple of elderly men who've had a stroke.
Yeah.
And the caregiver staying back is a daughter, okay? And the daughter is frankly pale. I mean, when you see her, she's so pale. And so I have to actually ask her how she's doing and, run a few tests for her. And if she's anemic, we start treatment for her as well. We have some women whose husbands have had a stroke. The women have never worked before, but now we're going to have to help them find vocational work and livelihood. And so we talk to them about, what they would like to do, where they see themselves going forward, because we tell them their husband's not going to work anymore now. So, conversations like that, of course, one-on-one with the lady in our room, but that time is spent for the patient and the caregiver.
Yeah, so there's
so
it gets pretty intense.
Oh,
that
yes.
means. So just to repeat her question then.
Yeah.
So you've described the method.
Yeah.
How do you cope with all the stresses that come as part of this?
So we, as a team, we every Thursday, we have a small self-care session in the morning. So we all sit together in my room, and from the beginning, I've always told my team that our place is a very safe space. So no one's going to judge you. If you're feeling vulnerable about something, if something triggers you, because I've said to them all that, look, all of us have cared for a loved one.
Yeah.
At
some point.
We've all cared for a loved one at some point. So something in the ward or something in our discussion may trigger you. So if that happens, please feel free to vent that to any one of us. Share with us if you're feeling vulnerable. If you need me to not include you in the round on a morning and you want to just sit in my room, that's okay too. But it's okay to not feel okay. So that's understood in our team.
So it does once a week.
On Thursdays, yeah.
Wow.
So Thursdays, once a week is definitely, like Thursday morning is fixed that we have our little self-care session. It's usually led by either our psychologist or our peer counselor.
lovely.
So I'm sitting there for it, but I ask them to take ownership. So they do these things like gratitude sessions, and it's just 20 minutes. Like, it's literally by the clock, but we do it.
What's a gratitude session?
So I'm sure you know, but it's nice. I mean, little things that you feel grateful for. Sometimes just talk about, in the last week, what did you do as a self-care activity? And we also get to know each other that way.
Yeah.
Like, you kind of learn that somebody likes singing, somebody else.
Yeah.
We actually just
Yeah.
make them sing sometimes. And it's just 20 minutes of just being ourselves. And then, when you're out there again, you're professional and you're not going to
So
be.
it's very interesting because a medical unit or a medical center to have and this is not exactly a hospital. It's not exactly a nursing home. It's something that kind of defies definition in the sense that not really defies definition. It's just that we haven't come across these kind of medical units too much, and just to see that there is a lot of multidisciplinary work, as is there in palliative care. There is a lot of focus on physician self-care,
Self-care.
physician or
The whole
team
team, yeah.
self-care. That's very heartening to see that we actually
It's a great
have
environment.
systems which
Yeah.
include all of this as part of the system in itself. That's lovely.
So, yeah.
And do you have people in your wards who are some of these outstanding performers, who just light up the ward? And
Oh,
these-
yes, we do. We had we had this young man from Uttar Pradesh, and he's given us consent to share his story. You might have even seen his photograph in the Times of India. Times of
wow.
India did a story about us, and the photograph was of Avdesh. And he was a migrant laborer in Bombay. His wife and brothers, family, and everyone was in Uttar Pradesh. And he developed Guillain-Barre syndrome. So, he woke up one morning, what he thought was just a normal cough and cold. And then in the next 24 hours, he had the classical symptoms of ascending paralysis, right? So he kind of, within 48 hours, he found himself paralyzed.
Yeah.
Neck down. Fortunately, the people he was sharing the flat with got him to KEM hospital in time. They started the treatment. And in the meantime, they called his wife and brother from Uttar Pradesh. And he was at KEM for about a month. And then when they finished what they could do, they asked if they could send him to us. So we said, yeah, please send him to us for neuro rehab. Because we have a lot of Guillain-Barre syndrome people coming to us for neuro rehab. And our policy is that not only the patient, but up to 2 of the relatives can also stay at the center.
Right.
So his wife and brother moved in with us. And it was just amazing to see him improve. Like, initially when he came to us, he had a tracheostomy in place, he had his Ryle's tube in place, he had a catheter. And it was so nice for us as a team as we removed one thing at a time. And when he was able to start swallowing safely, the Ryle's tube came out, his fingers started moving slowly. His wife used to feed him. Then we asked her to just move the table up, put the food in front of him, and for some time just guide his hand. And
Oh, wow.
so we started guiding his hand, then he started feeding himself. And once he was able to use his hands and upper body, he just made this quantum leap in his recovery because he suddenly felt so much better.
Yes.
He was with us for a long time. I think he was with us for at least 6 weeks to 8 weeks. He was with us for quite some time. But he, would, if we gave him the static cycler, he would pedal with his hands and just, work on himself. And his wife and his brother were really helpful. They're part of the photograph in the Times of India. They were very excited that they made it to the Times of India. And he became our kind of, then he could mobilize to a wheelchair and he'd propel himself.
Yeah.
So he would actually go to each bedside and talk to everyone.
Lovely.
And then he would lead the carom matches. We have a carom board, and so we would get him.
That's for the patients.
The
play-
patients,
oh.
yeah. So people recovering from a stroke, as soon as we're able to mobilize them to a wheelchair, we have them sitting around a carom board and they
play.
start playing. Yeah, so.
This just reminds me of Munna Bhai MBBS. That juice pivanu, carom ramvanu, Majani life. There's a scene where they do that.
Yeah.
Okay.
But it's very interesting that you are actually also doing neuro rehab.
Yes.
And so this is not exactly a traditional palliative
It's not
care
traditional
center.
palliative.
How will you define, what the center does?
So what we first of all feel that palliative care, and we want to just sort of look at the definition of palliative care, right? So first of all, we believe that palliative care should start from the time of diagnosis of a distressing, any distressing or serious condition, right? From the time of diagnosis. And I'll come to an example for that in a bit, but just remind me to talk about tuberculosis and the role of palliative care in tuberculosis and adherence. But so we feel it's a lot of supportive care. We do believe that there's a lot of rehabilitation involved. So we have a full-time otist with us who also, by the way, part of our multidisciplinary team is our otist. So she's
an occupational
also,
therapist.
Occupational therapist, our occupational therapist. So another essential part of our work is rehabilitation. And what do we offer is, of course, the symptomatic part of it. So pain, breathlessness, the entire list of, the negative symptoms that you would list in a classical ESAS, right?
Yeah.
But beyond that, we look at positive things as well. So how much more mobility can we give this person? What if we were to try to get this person independence to a certain extent?
Yeah.
And even if they're a certain age, like we had a 68-year-old who'd had a stroke. He lost the use of his, obviously lost the use of half of the side of the body. Swallowing was an issue. But he was with us for quite some time. He was mobilized to the carom board. And he used to say to us that he felt like eating Bhangra curry because he was basically from Goa. So we said to him that let's aim for that then. And we said to him that one day you're going to actually clean your own Bhangra because that's the hardest fish to clean, right? And you won't believe it. He went through all the neuro rehab, everything with us. And when he went home, a week later, his wife called us on WhatsApp. She made a video call. And she said, I want you to see this. And there he was cleaning a piece of Bhangra for us.
Amazing.
So, and those were, so again, is this scientific? I don't know. But goal of care is that you will clean your own Bhangra and eat it. Right?
and also have smashed pani puris.
Yes.
Food.
Yeah.
So much around food.
Joy.
So much goes
yes.
of care around
Oh, yeah.
food.
And we believe that food is more than just a nutritional requirement. There's a huge social role in food.
Social, emotional, like so much around it.
We don't typically admit pediatric kids because we don't have pediatricians on staff yet. But once, just after the COVID pandemic, we had a 16-year-old admitted to us, and he had a very rare neurodegenerative disorder. And he was just shifted from one of the municipal hospitals. He was shifted to us at night. So when I got a call from the sister, I said, we can't send him anywhere else now. Where does he live? They said, Dharavi. I said, okay, so we're not sending him home. We'll keep him with us. And he was having swallowing difficulties, and it was quite hot at that time. So his mother naturally wanted to give him water. And we couldn't safely give him water orally. So one of the things we do at our center is for everyone with a Ryle's tube, we have a misting bottle at the side of the table with drinking water in it. And we mist the mouth every half hour so that there's no sensation of thirst and dryness. So the water requirement is going through the Ryle's tube, but that relief that you get when it's hot, that's coming from the mist. So we've introduced that, across the whole thing. But here was a kid who he was 16, but still he was a kid. So, I just checked up a couple of resources abroad, and I noticed that people use jelly abroad. And jelly is safe for someone with swallowing issues.
Yes.
So we went to a grocery store, and I kind of just asked the guy for all the flavors he had and went off to... And we have a little pantry in our center. So we taught the mother how to make jelly. And then we said, we can start serving. So the first mouthful, she was scared to feed him. She was scared he would cough. So she asked me to feed him. So I still remember the look of joy on his face. It was a raspberry flavored jelly. And
Those things taste amazing.
they taste amazing.
They taste amazing.
And here was a
I'm
kid.
transported back to my childhood
Yeah.
just now.
So I still remember the look on his face. And this was a child who'd grown up in Dharavi, so maybe he'd not had jelly before. And that's how we kept him hydrated for the days that he
They're
was with him.
amazing.
And then we asked him which flavors. We every morning we'd put the boxes of jelly on his lap, and we'd say, because he wasn't able to sit up on his own, his neurodegenerative, it was a neuromuscular condition. So, his muscles were wasted, his swallowing was affected. But we would just show him the different colored jellies and say, which one should we make today? And he was so happy to just choose different colors, right?
So,
And
so we've already gone through the list, the menu today. It's been pani puri, it's been mawa cakes, now it's been bangda, and now we are jelly. So we see how heavy the
Yeah.
topic has been for,
on food.
Food
on
centric.
food. Yeah. So you have a community health vantage point. You are also doing a bit of neurorehabilitation related work. So it's very comprehensive in that definition. Which brings us to what you were asking us to remind you about, how
yes.
the definition of palliative care and the tuberculosis compliance comes in. So you're saying something about it.
Yeah, so literature across the world is different about palliative care. So in some countries, a referral to palliative care is when there's a life expectancy of 6 weeks, okay? Now, this is generally in countries where there's third-party payers involved, so either insurance or the government system. So it's about the finance and how much time they think the person has.
It's linked.
Yeah, it's linked. Our definition is that because it's from the time of diagnosis and it will be given alongside disease-modifying therapy,
Yeah.
and it's to address distressing symptoms arising either from the primary illness or from the side effects of the
The
therapy.
treatment itself.
So, and the classic example for this is in patients with tuberculosis.
Okay.
Patients with tuberculosis, first of all, the drug regime itself can cause a lot of side effects.
Correct.
The side effects are distressing, and oftentimes, because we have worked with Médecins Sans Frontières and we kind of understood the issues of people living with tuberculosis. And one of the reasons why there's a high dropout rate on medicine is because the side effects are so
Are
distressing.
so bad. Yeah.
And the sad thing is, a high dropout rate is obviously very bad for the patient, but it's also very bad for the community at large.
Yes.
Because at some point you're going to have a lot of untreated people who are potentially communicable. So
More
this is
patients with
is not to
tuberculosis.
stigmatize anyone, but I'm just talking about it from a community-based thing.
Yeah.
That if someone is still infectious, but they're still being, moving around, then it's risky even for the children in their house, for other
It's
people.
the reason we
Yeah?
vaccinate.
Yeah.
All of this.
So first of all, dropping out of a treatment protocol is not good for themselves. It's not good for the community.
It's not good for anyone then.
Not good for anyone. So if you can start palliative care earlier and you can actually address the symptoms that they're facing and you can address the nutritional, because another thing with patients with tuberculosis is, and I'm saying this because we've actually had a few patients with non-pulmonary tuberculosis admitted with us. So we've had a few POTS spine, right? So the tuberculosis of the
Affects the spine, the
of
vertebral-
the
the-
vertebral
yeah.
column. And the first thing we notice is their appetite is really bad because the medicines make them feel very sick. So we have worked with, giving them antiemetics, trying to just work around the symptoms and getting them to adhere to their treatment protocol, getting them to be nutritionally supported.
Yeah.
And they actually finish the course, okay? They
Yeah.
finish the course because this support is given to them. And so therefore, it actually increases their life
So it's
expectancy.
no longer that definition of
Yeah.
life expectancy.
So it's no longer about
This is
okay,
very
6
far
months.
away from
Yeah.
starting palliative care for someone who has 6 weeks to
Yeah,
live, right?
this is like giving this person more. I mean, I don't know if it's necessarily more time, but it's certainly not planning for their death. It's
No.
for
It's for their-
helping them finish their treatment
Yeah.
and live longer and be comfortable.
But do you think this definition of defining, this palliative care prides itself on talking about quality of life, not necessarily the longevity? We want a long life for sure and a good quality life. So when you tie this definition up with longevity, as she mentioned they do in certain parts of the world, do you think that approach will work in India the moment they say that palliative care is going to come in? because the life expectancy is limited and you define it by a number, say 6 weeks. Do you think that approach will work in India?
No, I think that this is what Leena said, right? That palliative care in different countries is linked to different things. So, if it is linked to whether your government or a third party
Who's
insurance
paying
is
for it?
paying for it, in a sense, we are not a country with universal insurance or universal health care, and so in that sense it is almost open to interpretation. This is the thought that I got when you spoke about 6 weeks to live and tuberculosis with
Yeah.
god knows how many years to
Yeah,
live going
yeah.
ahead. So I'm just thinking it just makes the whole definition so confusing, right?
Exactly.
It's almost as if you are using palliative care as a placeholder for different things, including end of life care, including respite care, including rehab, including additional support systems. So sometimes I feel that because we are a country where we are just beginning to understand what palliative care means to us, given our medical system, we are actually trying to fill in so many unmet needs.
Yeah.
And maybe a few years down the line, we will have a more concrete idea of what it is. I'm pretty sure it's not going to be someone with 6 weeks to live
Yeah.
only can access
Yeah, but
palliative care.
that definition may not necessarily. What do you think?
I think there should be, I think in India, luckily, we're at a stage where we can still define it and make it less
Yes.
restrictive. And therefore, it should be like a continuum of care, right? So like there's a continuum or like a spectrum. Yeah, continuum. So it starts at the time of diagnosis and it goes right through alongside whatever that diagnosis may be, to a point where maybe now we do have to deprescribe. We do have to say that maybe this medicine is not going to be beneficial. This intervention is not going to be beneficial. And we move into hospice care, which will be focused mainly on comfort and symptom relief. But again, it'll depend from institution to institution, but generally you would stop interventions that would be seen as aggressive or, you know.
Yeah.
And then end of life care, which is completely supportive and comfort care. And then, of course, bereavement support for the loved ones who are left behind.
Yeah.
So I think there has to be that continuum. And for me, that would be the definition of
And
palliative
somewhere
care.
along this is what they call hospice care,
Yeah,
where they
hospice
say
is part of that
Part of
continuum.
that,
Yeah.
part of
Yeah.
that. But you know what I like? I like that term which is called as care coordination. And so what it means is when you it makes it personal. So when you identify case to case, you see what is the lacuna that is needing here, that is there here. So what is the unmet need here? Is this a patient with tuberculosis who needs additional nutritional support or symptom management support? And so palliative care then rushes to fill that gap in using any resources at their disposal. I could use government schemes to be able to support that nutrition, or I could go to Sukoon Nilaya and say that can you keep this patient for a month to make sure his nutrition rehab is good, or I could use NGOs. But what is happening is that around the world, especially in India, I'm thinking that palliative care is trying to just identify unmet needs which may be different from case to case and try to see how to fill them.
In most serious illnesses, whether there are unmet needs, you come in and
You
fill
come
that
in
gap.
and you fill that gap. And so that's the reason why it's a little vague at the end of the day. But I feel that care, when you talk about it in terms of care coordination, it fits into then that's when the jigsaw puzzle kind of
The pieces
fits.
fit. So you mentioned the story of Avdesh, who's given you the permission to share his story. Do you have any stories of geriatrics? Some because we know some of the senior citizens can be full of personality. You know, do you have any?
Yeah, so we have the gentleman who recovered from the stroke. He was our geriatric hero, sort of. So he actually was able to get over his stroke.
The Bangda,
Yes,
the
and
Bangda
clean
story.
his own Bangda, or we had another lady who was with us, also recovering from Guillain-Barré. She was maybe in her late 70s.
Wow.
And a retired school teacher. So as soon as she got her speech back and she was able to sit up, she decided she would start teaching English to our nurses. And she wanted to have English classes and teach people. And so
She's still doing that?
So she was ultimately discharged from our center, but
In the
yeah, when she
center.
was with us, she wanted to start teaching and, wanted to volunteer with us. So, in fact, that's what we actually say to all of our patients. We always say to them that as soon as you're a little better and you're able to mobilize a bit, you're not a patient. You don't have to be restricted to the bed here. You're now going to become a peer counselor for everyone else here. So do
Right.
encourage them to move around. And I feel that our ward is more of a community than it is a ward.
Yeah.
Because many times people have been there long enough that they get to know each
Each
other.
other.
You have one young lady who's there caring for her father with a stroke, but she might know how to put mehndi on. So one evening, she's like putting mehndi on everyone's hands in the ward.
Wow.
So it's like, it's really, we've had some really sweet moments. We had a lady who was, she had end stage pulmonary, she had interstitial lung disease, so she had fibrosis, and she was always on the oxygen concentrator, and she had said something very sweet to us when we had a goals of care conversation with her, and we asked about escalation of care. She said, whatever happens to me, I want it to happen here with all of you around me. She said, you don't even need to call my family as long as you people are around me. So that was very touching.
Very touching, absolutely.
And what was most touching about her is, this is kind of hard to narrate, it's very emotional, but the day before, like, we didn't know she would pass away that night. That the day before that, when we were on rounds, one of our volunteers was wearing a particular shade of nail polish on her hands. So this lady remarked that it was a very nice shade. So a little later, the volunteer got that shade and sat down, and we have a beautiful picture that we took with the lady's permission, but it's from the back, but she's still hooked to her oxygen concentrator. She's at 10 liters. So we've told her that this is going to be the maximum we can give. If SATs drop beyond this, we can't do any more than this. She said, that's okay. So she's hooked to her concentrator, but she's given her hand to the volunteer, and the volunteer is putting that nail polish on for her. And she was very happy that day. I mean, she met all of us on our rounds. She showed everyone the nail color and everything. And then that night she passed away in her sleep. Wow. And I remember the morning when I walked in, and I was the one who had to certify it. It was such a mixed emotion for me because absolutely. I knew that we'd done the best we could, and I knew that she would not recover. But I was just grateful that in that last day, we were able to do something, that just gave her that joy. She went to sleep happy that night. And then,
No, this is a beautiful, very touching story. In fact, I'm moved. I'm just thinking that does it help if you were to set up an ideal palliative care ward? Do you think the era of specialization, like we specialize in palliative care, we make it geriatric palliative, pediatric palliative, oncopalliative. But what you describe here seems to be a ward, a community, which is, again, it's as diverse as the population outside. It's just that they are vulnerable and they are all together. And in that moment, they are still looking out for each other. That's very inspiring. And do you think that should be a model one should aspire to, rather than keeping separate, because palliative care, when we talk about it as being there for the family and for everyone, and again, we are trying to make that inclusive thing exclusive. So I just thought of this, and this is what if I have the resources, probably we'll have a center where we'll do something like you're doing, it's brilliant. I'm very moved by what you said.
Yeah, it is every day is very moving there. So to come back to the question that you and I discussed earlier, is the work depressing?
Not at all.
No. So what happens is there are moments of sadness. I would say that. There's moments of sadness. There's days when I know a lot of my team members, because the Thursday meeting, when we all reviewed what was difficult for us, everyone mentioned the same lady. Yeah. Everyone said that, it was hard. Like we all knew it was coming. And yet when it came, it was difficult for us. Just because we had become so close to her as well. Because a lot of our patients are with us long enough that we become very close to each of them. So,
this is what yeah, I mean that's kind of like an answer to the is this
Yeah.
depressing? But now I want to ask you the question that we ask everyone who comes on to the podcast. What does living well mean to you?
So, in general, so me as an individual or for the patients?
For you, for
For
you,
me,
for you.
I think living well would be, waking up in the morning with a purpose. So you just wake up, looking forward to, you know, um, first of all, interacting with your family members as soon as you wake up. Then, getting into your car and hoping the ignition starts at the first attempt. Little things like this. I live very close to a school, so my morning getting to work on time is completely dictated on how many school buses are blocking my road. So, one happy moment for me can be as I turn, I see only 2 school buses and I'm like, yay. Some days there'll be 6 and I think, oh gosh, but little things like that. And then, of course, getting to work, meeting my team, meeting each of the patients. And I mean, honestly, Sukoon Nilaya is now 3 years old. So I've been there for 3 years, and every single patient has been a source of inspiration. So living well would be also just looking forward to your work, then looking forward to your non-work time as well. So, I like cooking. So things like cooking or just
I wouldn't have suspected from our conversation.
So I would have liked to laugh, but I've got a bad throat.
I'm sorry, but I just couldn't resist after discussing 4 items in the menu and like,
Well, food is very important for me.
oh yeah, I wouldn't have suspected.
For me, the act of cooking cooking as an act is very healing for me. It's just very, as I said, some of these little things, like there was this very senior lady who used to live in our neighborhood, and she was alone. She didn't have children, and she'd lost her husband. She was all alone, and she once phoned up on our landline, and she said to me, I'm saying landline because she was so old-fashioned, she didn't have our mobile numbers and things. So I thought, like, who's calling on the landline? It was this very senior lady. She said to me that, I'm just recovered from a flu. I have no appetite, but I really feel like having this particular dish that your mom makes. So can you ask your mom to please make it for me, and can you bring it up? So I said, okay. And I hung up, and I thought, Mommy's in Canada right now. So I kind of thought, okay, so now I just have to recreate this dish. And I really didn't, I just did it from memory because it was time zone wise. I couldn't even phone my mom and ask what the recipe was.
I'm very curious.
So
What
I
dish
just,
was it?
What dish was
it was just we're Saraswats, so it's a South Indian way of making potatoes. It's very simple,
Okay.
but they're cooked with coconut oil, so they have this particular flavor. Grandmother made it very nice. My mom made it very nicely. I had no clue how to make it, but I just remembered that there was potatoes and coconut oil in it. And I thought, okay, I'll figure out the rest now. And I remember just standing in the kitchen and making it and packing it, and then just walking up, Forget Hill, and dropping it off for her. And I sat there with her, of course, as she had it. So these little moments, like even cooking for someone, or food is very, very healing for yourself. It's healing for others. And that's why it's such an important part. Like even with all of my patients, I always ask, what kind of food does this person like? What would they, if we can get them to eat again and we move them from the tube to a dysphagia diet, what is the first thing you think they'd like to put into their mouth? And then we allow, obviously, Sukoon Nilaya, we allow food from home. And we've had some team members who are so, we get so invested at the center.
Yeah.
We had a lady who had no family members, and she was with us, and we didn't know what to do because KEM Hospital found her on the road. The police took her to, KEM didn't find her. The police found her. They took her to KEM Hospital. They didn't know what to do, so they sent her to us. And we didn't know what to do because no family members, no history, nothing. And she was initially not verbal. She wouldn't talk to any of us. But we just kept her near the nursing stations. We could keep an eye on her. And she initially refused to eat as well. And we didn't think it was an indication for a Ryle's tube. We thought she might find that very frightening and distressing. So we used to just keep her lunch in front of her and give it to everyone else. And then in a day or two, she started eating it. And then we would kind of just encourage her. And she started talking to us. And then we realized, I don't know, she told one of our nurses that she felt like having fish. So I still remember one of our nursing team actually made it at home and brought it
Brought
in
it
for
for
her
her. So
because
sweet.
there is no other family. Like, so we just become family for these
Yeah.
people.
So all those
So
pieces
little
that
things,
define those moments that you say that
And-
define living well
yeah.
for you, you know.
So living well is just doing these little things. So yeah.
Wow.
And then
That's lovely.
this lady loved crocheting, so we used to get yarn for her.
Hmm.
And she would just crochet the whole day. So suddenly our ward was like this kind of table runner on our nursing thing, and then torrents on all of our doors, and it was like just she was
Everywhere.
crocheting faster than we could get yarn for her. But it just gave her so much joy. Yeah.
This
So
is
it's
what
like,
this is what
like
we
these
always
little
say,
moments.
no? That palliative care is just all about the stories. It's
Yeah.
just wonderful stories. Like one of them is so different from the next, but they all have this common thread. Like you want to belong, you want to experience joy, you want to share it with someone, you want to have someone who cares for you, and so even if, like, no matter how far you get along in medicine, that the fact is that you are caring for a human.
Yeah, you
Yes.
put the
And
science and the
this-
community together and
and-
magic happens. you know.
Yeah,
Yeah.
and then that shared humanity, the thread that
Yeah.
runs through it is
Yeah.
the same.
Brilliant.
Lovely. Thank you so much.
It's really wonderful. In fact,
Thank
very
you.
moving. There were quite a few moments where I was really touched by the stories that you've brought here, and it's amazing.
Thank you.
Yeah, and more strength to you. Keep doing what you're
Thank you
doing.
so much. It's really it's lovely talking to you, and it's really a privilege. I just feel privileged that I've been able to be
Yeah.
associated
For an
with.
ant, you've done really well.
Thank you. Yeah, I just feel very privileged that as an aunt I got onto the right knapsack. But yeah, so I mean, King George V Memorial and Cipla Foundation have really supported us a lot,
Lovely.
and yeah, so
Thanks a lot, Leena.
Yeah,
Thanks a lot
thank
for coming on to us. I know it was a bit of a travel for you.
but
And with your throat and with the
yeah.
Thank you.
Thank you.
Thanks a lot. Yeah.
Thank you.